get started. Okay with you, Kate?
Sounds good.
So thank you everybody for joining. I'll be hosting today. Srinath was not able to be here. So it's my pleasure to introduce Dr. Kate Saul. Kate's an associate professor in the department, and she has been with us since, I believe, 2013. Hopefully I got that right. Kate earned her undergraduate degree from Brown and her master's and PhD from Stanford. She really has too many awards and accolades to list in both teaching and research, including being the NCAA Woman of the Year while at Brown, which I've always found particularly impressive, but may actually be one of the least impressive things on her resume. So today she'll be talking about understanding upper limb injury and function through integrated musculoskeletal modeling. Take it away, Kate.
Great. Thanks, Landon, and thanks everyone for coming today. I'm excited to talk to you about the work that we do in my movement biomechanics lab. When we are thinking about the musculoskeletal system, which is the foundation of the work that we do, it's important to understand what that really means. And what we're talking about is the coordination of muscles and muscle tendon actuators to animate the skeletal system in the body. And the complexity starts really at the molecular level, but for today's talk, we'll start at more of the tissue and macro level of muscle and bone. Each muscle and tendon has a unique arrangement of muscle fibers and tendon that govern the way it produces force and how much force it can produce. And the way that it animates the skeletal system also depends on how the muscle itself is routed, where it connects to bones, and how far away from the joints it's located. So I've given a little cartoon example here of the biceps, where you can see already it has a complex pennate or angled structure for the fibers and a bifurcating tendon as it connects and passes two joints in the upper limb. But of course, the system's even more complex than that, because each joint is crossed by multiple muscles on both sides of the rotational joints. And taken together, what we have is anatomy that has been detailed and function at these joints that have been detailed in hundreds and hundreds of studies, from anatomical dissection and imaging and functional assessments. And that's really not a practical way to understand what the system does, especially in novel motions or in novel scenarios where muscles are injured or disrupted. So the approach that we take is to replace all of this wealth of anatomical literature with mathematical representations that allow us to interrogate the system and understand how it will perform under a whole variety of scenarios. Where we sit is sort of within the flow of how motion is produced physiologically between the neural control system, illustrated by the brain and the spinal cord and the nerves on the left, and connecting that to function, which for the upper limb, which is our lab's focus, can be very complex. Rather than a cyclic motion like walking or gait, we have a whole variety of tasks that the upper limb must produce. It interacts with the environment and people around us. It can perform dexterous tasks, but it also can perform feats of strength. And by using computational simulations, we're able to understand mechanically how this link between the intent of the system and the actual function that's observed is produced. So our lab is very much interested in how the particular structure of musculoskeletal tissues in healthy and in impaired individuals relates to the function that's possible, and how specific injuries or interventions like surgical repair of a nerve or of a musculoskeletal tissue relates to the function that can be expected. And this is extremely important for clinical outcomes, where patients present with a wide variety of injuries, and surgeries or therapies might happen maybe multiple at a time. And so it can be very, very difficult to tease apart why a particular patient has a good outcome and another patient does not. So at the heart of what we do is to use mechanics and musculoskeletal modeling in order to put these pieces together and make predictions that can help improve quality of life for patients. The clinical and engineering challenge is sort of multifold. First, muscle and bone tissues are dynamic tissues. So when we look at a particular snapshot of the state of a musculoskeletal system, that's going to change over time. Their mechanical properties of muscle and bone will change over time. It depends on the structure at both the macro and the micro levels. It depends on the usage of those tissues, and it depends, of course, on time. It's also difficult, as I just mentioned, to understand the particular influence of a specific injury or a therapy on function or tissue loading when you think about in vivo in people, because there are concomitant effects. You might have a rotator cuff injury, but at the same time, you might have a shoulder dislocation, or you may have a tear of another structure in the shoulder. Or you may receive a surgery to repair one tissue, but at the same time be receiving physical therapy. So it can be very difficult to tease apart which of these factors is really leading to the outcomes we observe. And of course, there's variability across individuals that we have to consider as well. And because of this, there's in many cases little consensus on optimal timing or approach for therapies after injury. And that makes it very, very difficult to make good clinical decisions to understand how to approach a patient and their care. So how can simulation help us? First, computational simulations allow us to investigate the roles of individual muscles and function and estimate parameters we cannot measure in vivo. There's a lot about an in vivo human musculoskeletal system that we cannot measure. We cannot measure individual muscle forces. We cannot directly measure the actual activation of a muscle, although we can estimate it from external measures. We cannot directly measure the joint reaction forces within a joint unless we have already replaced that joint with an implant. So there are things that we can only get at and estimate through computational simulation. We can predict outcomes following injury or treatment strategies that allow us to have a better foundation to make clinical decision-making. And we can predict the response of biological tissues over time and their influence on tissue structure and function. So to do this, we use a musculoskeletal modeling approach, which represents the dynamics of the system. It treats the limbs segments as rigid bodies and the joints that are acted upon by muscle tendon actuators to produce motion. And many groups use a similar approach to approach other different parts of the body. When we think about these musculoskeletal models, as I said earlier, they're basically a library of experimental data that defines the joint kinematics, that is how the bones rotate relative to one another. That's usually measured from medical imaging like CT or fluoroscopy. Muscle architecture, which is the arrangement of muscle fibers that are internal to the muscle and the tendon, and tells us about the length and cross-sectional area, basically the amount of contractile tissue in series and in parallel in a muscle. That's usually obtained from dissection or medical imaging. Muscle paths, which tell us the route that a muscle takes, where it attaches, how far it is from a joint rotation, what its moment arm is. And then finally, muscle activations, which tell us which muscles are on and when and how much, which we can estimate from experiment, which I'll talk about in a minute, but also more often is estimated using theories of motor control or optimization methods. I have 4 purple boxes, and really I should have 60 or 100 because these data come from so many different individual data sets that are combined into a single model. That allow us to make predictions of functional outcomes at the muscle level, at the joint level, and at the whole body function level. Once we have a musculoskeletal model, we can use it in the context of a dynamic simulation, which moves through the physiological pathway through which motion is produced. It starts from a neural command that comes from the brain and excites the muscle, and we represent that as a series of pulses that is transformed into an activation state for the muscle that has an inherent delay built in because of the physiology of muscle and how there is a need for calcium diffusion in the muscle to go from the electrical signal to force production. We then think about the muscle tendon dynamics, where at each individual muscle within a model is represented by what we call a hill type muscle model, which captures contractile elements that depend on force, depend on velocity, the length of the muscle, and the activation state of the muscle, as well as passive properties. If you think about a muscle as sort of a nonlinear, rubber band that resists stretch or to be overstretched, and tendon behaves similarly. So depending on the length state, the velocity state, and the activation state of the muscle, we can determine what the force is. That force, just like any other system, is transformed into a rotational moment around a rotational joint like the elbow or the shoulder using an estimate of the moment arm based on its path and arrangement. And we have graphical methods and mathematical methods for estimating what that path would be for any posture in the upper limb. And then we use standard dynamic techniques in order to predict what the state of the joints would be in terms of velocities, positions, and accelerations. Because all of the actuator states, basically the muscle tendon behavior, depends on position and velocity, this is all part of, physiologically part of a feedback loop, and within our simulations, these dependencies are also captured. So we inform our simulations using experimental measures of real human motion, which we capture using a variety of different tools. We use motion capture to assess the postures and the velocities and accelerations of a limb while a person performs relevant tasks. We use electromyography, which is basically an electrical sensor that detects the electrical activity of a muscle that tells us something that's proportional to the force produced by that muscle. We measure the strength that individuals can produce with dynamometers and their interactions with the environment using force plates and other force sensors. We measure the metabolic expenditure that, or the oxygen consumed by an individual when they're performing a task. That allows us to have estimates of efficiency for motion. And then we make direct measurements of muscle structure, either through dissection, shown here. We use laser diffraction and microscopy to look at the internal structure at the molecular level of muscle. This is taken in vivo during a surgery in this example. And then we use a lot of medical imaging to get really robust direct measurements of shape, of bone, of fat content, of muscle volume, so that we can personalize our models to represent specific people or populations. And finally, when we can't make these measurements in humans, often we do use animal models that allow us to get more robust measures, not only of the anatomy and their function, as on a little treadmill shown here, but also of what's happening at the cellular level there, as well as molecular signaling. So I'll touch a little bit on how we put these together using one quick example of how you would merge this information from experiment into simulation with some of the work that we're doing with Greg Sawicki on exoskeletons and how they affect walking neuromechanics. As you can see here on the left, you'd have an individual who's walking with an exoskeleton on, and I don't know if you can see my arrow, but there are little silver balls that are the marker measurements. There's also underneath this wrap sensors that are measuring muscle excitation. And we can use that in a simulation to have our lower limb model track how the person walked, to have the muscles stimulated the way that the EMG detected that the person was using the muscles. And that can tell us something about how those muscles are producing force, what the efficiency is of their walking. And this is all essential information to understand how best to design an exoskeleton so that it actually helps the person and doesn't harm the person or have the person use their muscles in a less efficient way that actually makes them more tired to walk with an exoskeleton than they otherwise would be. So these are the kinds of things that we can pull together. So today, though, I'd like to focus on sort of two main areas that we work on in our lab, predictive function and modeling, and brachial plexus tissue development, which I will define all those terms in a little bit. So overall, when we're doing our predictive function analysis, we have a general simulation workflow, and it always starts from thinking about the patient population that we're interested in. And the way that we do that is by engaging clinicians. We've worked with a number of clinicians at a lot of medical centers that we continue to have these partnerships. And we start from them because they are close to the patient and they understand what the relevant concerns are and what their clinical questions are. Typically, these are questions regarding understanding what the underlying mechanics are that are driving patient outcome, or concerns about different treatment strategies that they're not sure which one might be best. So when we talk to the clinician, what we take away is information about what changes they see and what changes they may cause when they do a treatment. And then we translate that into our engineering parameters that are implemented in our model. And that may change any of those sort of boxes that I showed you about the model. And we would directly represent those parameter changes. We might have information from specific patients that we use to personalize the models. And then we would simulate relevant tasks. And these might be tasks such as maximal exertion, so we can estimate strength, or they might be submaximal movements that are relevant to activities of daily living that a person needs to be able to perform to be independent, like feeding themselves or hygiene, or in a work setting, it might be some sort of ergonomic task, or in a military setting, it might be, you know, being able to work with some piece of equipment. And then we choose from those simulations clinically relevant outcomes like strength or range of motion or joint loading, things that clinicians might measure or care about, in their clinic, so that we can make comparisons to the literature and translate our work in a way that is understandable by clinicians, so they can use it to inform their treatment. So in the brief example I showed you, we were looking at the lower limb, but our lab's focus is mostly the upper limb, and that is simply because it is a more interesting and much more challenging system. While most joints in the body are sort of simple rotational joints, the shoulder in particular is a very complex joint where there's sliding of the shoulder blade or scapula on the torso, and the glenohumeral joint, which is shown here, which is typically treated as a ball and socket, is really more of a ball on a shallow cup. So there's a lot of mobility and a lot of potential for injury. So I just want to orient you a little bit to some of the anatomy, since I'll be using some of this terminology. Highlighted here is the glenohumeral joint, which is the most mobile joint in the body. When we look at these bones, because of that level of mobility, there's quite a bit of connective tissue in terms of ligaments, and then the muscles are also used to stabilize this joint. I'm also on the right showing you and sort of an end-on view of the glenoid cavity of the scapula. Often when we're thinking about the stability of this joint, we'll think about where the loading center of pressure is within this boundary, and so there'll be some images that are looking end-on, and that's what we'll be portraying. In terms of the muscles, perhaps you're familiar with some of these muscles, the deltoid and pectoralis major and some of the superficial muscles. I want to draw your attention to some of the deeper muscles, in particular the muscles of the rotator cuff, which have a special role in stabilizing the glenohumeral joint. They share a common cuff. It's very commonly injured. And the role of these muscles is really important for some of the clinical scenarios I'll be describing. So we have developed a series of upper limb models, which are the most widely used upper limb models in the world. They incorporate the inertial and anthropometric properties of the upper limb, and it can be scaled to represent people of different sizes. We include passive restraints and damping at the joints that represent those ligamentous structures that I described, and the force, length, velocity behavior of muscle for all of the muscles crossing the shoulder, elbow, forearm, and wrist. And of course, anatomical muscle paths. And this is made publicly available. All of our models and all of the computational tools that we use, that we develop, are made publicly available and shared with our community. So we've used this for a couple, many different topics, which I'll share just a few brief snapshots of. For example, we've used this to look at how rotator cuff injury and repair affect function. So we've integrated that model with direct measures of muscle anatomy from MR imaging. We've described mathematically what the fat distribution within a muscle is and how that affects its contractile nature, and made direct measurements for specific individuals of what their loading at their shoulder is, how different, how rotator cuff injured patients and control patients of the same age change the loading of their shoulder. We can see that their joint reaction loads are misdirected, and we can even identify specific people who are the dots near the edge of the oval who have risky loads that put them at risk for serious injury to their glenohumeral joint. And we've been able to show that those are the same patients who are experiencing more pain or who are experiencing a re-tear. So we're really able to make patient-specific decisions and recommendations based on our models. We're recently working with the Army to also incorporate our modeling into their operational requirements-based casualty assessment, which is a framework to evaluate battlefield insults, specifically looking at penetrating wound injury and how that changes the structure of muscle, obviously, but specifically looking at how for a given service personnel, when they experience a specific penetrating wound injury, whether they would be able to perform specific tasks and what the detriment to their function would be, so that ultimately we can make decisions in the field about who needs to be extracted and what types of tasks they would be reasonably able to perform given a specific injury pattern. So the other thing that we do with this work is not just answer those specific questions, but because we're leaders in the modeling field for the upper limb, we're also really interested in understanding how modeling decisions influence the predictions that we make and developing best practice recommendations for the field about how to capture the motion of the upper limb. And the most important question we have in the shoulder is the glenohumeral joint, because it is such a challenging joint to measure. Most models, including the model I've shown you, use an inherently stable ball and socket joint to represent that glenohumeral joint. We have the motion of the scapula and the clavicle, but most models don't allow direct prediction of translation in the shoulder. But in vivo motion does involve a little bit of translation, especially when there's an injury to the rotator cuff. You tend to have more motion of the humeral head in the glenoid, and it migrates superiorly, which can cause arthritis or impingement in the shoulder. In vivo, what happens is that multiple muscles on either side of a joint co-contract to stabilize the joint, which means that instead of just having one muscle on at a time to rotate a joint, you would have muscles on both sides activate simultaneously, which sort of stiffens the joint, and that's how it's stabilized. But most optimization methods would penalize that, because most optimization methods for musculoskeletal motion prioritize efficiency. So for the shoulder in particular, this can result in poorly predicted outcomes. So we've done some work with my recent student, Daniel McFarland, to understand how sensitive our simulations are to the different modeling choices for incorporating stability. And the two main approaches are either to measure muscle activity and directly include that as a constraint in our optimizations where we're identifying muscle coordination patterns. Typically, you only have maybe 4 to 8 muscles that you would be measuring, and there could be 25, 35 that are crossing a joint. So, that's sort of a subset of the muscle information that you would need. The other alternative is to mechanically constrain the direction of the joint reaction force to fall within empirical limits for what they ought to be in any given direction of the joint. And so we incorporate these constraints and systematically look at how they influence not only stability, which is what they're trying to incorporate, but also the joint reaction force magnitude, and activations of muscles that are not part of the stability constraint. So rotator cuff activations would not be measured because those muscles are so deep. So we can use that to understand whether our simulation outcomes are sensitive to that. And what we found is that EMG constraints are not great. they are extremely, the activation for the rotator cuff and the joint reaction magnitudes are extremely sensitive to how you implement EMG constraints and how many muscles you constrain. And this makes sense because models are imperfect representations. The strength of a model may not exactly represent the strength of your person. There are a lot of modeling choices you have to make about how many muscle paths represent a single muscle that has a complex architecture. But even if you had a perfect model, EMG is imperfect. It is a signal of electricity coming through skin and fat from a muscle and its surrounding muscles. So there's a lot of noise. There are decisions you have to make about normalization that are imperfect to get from voltage to activation. And it's essentially converting EMG to force, which is not really a direct relationship. In contrast, we found that force constraints are extremely robust. They are, our outcomes are very insensitive to the way in which it's implemented. And more important, the activations and the forces are consistent with literature descriptions of what those activation and forces should be, whereas the EMG constraints tend to make them a lot higher than they ought to be. So we can make best practices recommendations based on this work if you're using a ball and socket. But we're really interested in expanding beyond that. So we've also begun with my student, Matt Berno and Morgan Dullman, incorporating a co-simulation of contact and pressure mapping in the shoulder along with the limb dynamics, representing directly what the contact is between the glenoid and the humeral head. Also in capturing some of that joint capsule type behavior that is around ligamentous structures that are around the humeral head, and directly representing the superior, middle, and inferior ligaments and coracohumeral ligaments as passive spring elements. So we're starting to really get more at some of these other non-muscular anatomy elements in the shoulder that underlie the muscles that are also acting to stabilize the shoulder. And in our initial simulations, we're able to see that the simulated displacements that we predict for the glenohumeral joint are consistent with what's in the literature, which is pretty exciting. So overall, what we're seeing in this portion of our work is that we develop widely used models and multiple custom software applications, including optimization, constraint tools, and contact modeling in the shoulder that provide insight into best practices for musculoskeletal modeling of complex joints. We elucidate neuromechanical adaptations to use of assistive technology. I showed you the exoskeleton, but we're also working with hand function and exoskeletons for hand function after stroke, and predicting functional outcomes following a whole host of injury mechanisms, treatments, and strength training. So the other piece that I'd like to dive a little bit further into is some work that we're doing that links this dynamic modeling to mechanical modeling of the tissue itself. And to do that, we're going to focus on brachial plexus birth injury. So before I describe the birth injury that we're interested in, I need to tell you a little bit about bone. We've been talking a lot about muscle and treating the bone underlying it as rigid bodies, but in fact, it's a dynamic tissue as well. And when we think not about adults, but when we think about developing musculoskeletal systems in infants and children, the bone and growth and development is complex. Bone starts as a cartilaginous sort of simple shape that over time experiences calcification, which turns it harder into bone. It develops a really robust blood and nerve supply, and it develops the characteristic shapes of the bones in our body. And the joint articulation surfaces have a very specific shape that enables their function. This is determined, of course, by the nerve supply, the blood supply, molecular signaling factors, genetic factors, but it's also highly influenced by the mechanical environment. And this has been discussed in as sort of a quintessential example described as Wolff's Law, where you can see the microstructure of bone even aligns very well with the directions of the principal stress that's been experienced by the bone. And the overall articulating the macro shape, the whole shape of the whole bone, is also related to the mechanics of the system. So this is really important in a developing skeleton, that you have the correct mechanical environment, because when you do not, you will experience deformity of these tissues. And that's really relevant in brachial plexus birth injury, which is the most common nerve injury in children. This results in a paralysis at birth that causes lifelong paralysis and postural and skeletal deformities that I'll show you. So this type of injury can occur during a difficult childbirth if the child is stuck in the birth canal. Basically, the neck and the shoulder become stretched away from one another, and that puts tension on the nerves that are coming out of the spinal cord and going through the arm, through the shoulder and armpit to control the muscles of the arm. And when these nerves become either torn sort of in the middle, or they become pulled out of the spinal cord, then there are paralysis of the affected muscles that are connected to those nerves. What this results in is both postural deformities. So you observe that the children have a range of motion that is altered. So these children down here, for example, he's not holding his elbow flexed. He cannot straighten his elbow. And if I went and put my hands and tried to straighten his elbow, it would passively resist extension. Similarly, the shoulder tends to be rotated in this way. But you can also see from CT scans that the bones themselves have grown improperly. So on the left side, you see a humeral head and a scapula that are kind of like an ice cream on a cone, and it sits very nicely in a cup. Whereas on the right, where it's deformed, the glenoid surface, which should be a nice little cup, is tilted backwards, which is retroversion. It's actually tilted downwards, which you can't see. That's called declination, and it's very flat. So that makes for a non-functional joint surface. And this is a lifelong consequence. So clinically, when they go to treat children who have had this injury in a severe scenario, there is debate over what the actual cause of these contractures and bone changes is. The prevailing theory for a long time is that there's atrophy of some muscles. So some muscles have gotten very small because they're paralyzed, and other muscles are not paralyzed, so they're healthy. And they are pulling on the joint against no resistance, and that is pulling the shoulder into internal rotation, and that makes it just sort of sit in that posture. And the other theory that's a bit more recent coming out of our group and others is that the muscles that are paralyzed are actually, they may be small, but they're short. They are not growing the way that they should. And so as the skeleton grows and grows, the muscles stay short, and it's like an overstretched rubber band that is pulling on the joints, and that is what is causing these stiff joints and this altered bone growth. And it's important to understand the difference, because you would treat them very differently. You would treat the atrophy imbalance problem by perhaps Botox of the intact muscles to create more of a balance. Whereas you might treat the impaired longitudinal growth by, say, a muscle release, by cutting the tendon of the tight muscle and loosening up the joint. So obviously that would lead to very, very different choices on the part of the clinician. So to answer this question, we just started from mechanics and said, which one is even possible to create these deformities? We can represent both of them directly in our model, and then we can look at whether posteriorly directed joint forces are created, which would be consistent with the type of bone changes we see, and whether they would contribute to contracture by looking at the range of motion that would be possible after these muscle changes. So briefly, we're looking down again at this same shoulder, and we're looking here, the orange vectors represent what The change in joint reaction force would be if you caused either a muscle imbalance or a shortened muscle for these specific muscles. So we can go muscle by muscle in a way that we can't in vivo to understand which ones are causing or could cause these changes. So for a muscle imbalance, we can identify 4 muscles that might be able to cause posteriorly directed forces if they were on and overactive and pulling the arm into this position. So that would mean that they could not be paralyzed. But most of these muscles are in fact paralyzed when you have this injury. So we can immediately rule out that muscle imbalance could even be a cause of this posteriorly directed force. In contrast, we can look at impaired growth and see that these 2 muscles would be, the culprits if they were too short, which would mean they'd have to be paralyzed. And indeed, they are paralyzed. And indeed, we have since obtained evidence in rats and in mice that these muscles are short. So our simulations are consistent with what we see clinically. When we look at contracture and range of motion, we cannot create a range of motion contracture with muscle imbalance, but we can create one with impaired growth in our simulations. And we identify subscapularis, which is one of the rotator cuff muscles, as one of the culprits. And sure enough, that's one that clinically clinicians have figured out just through their empirical work with patients that if they release it, that it increases range of motion in the shoulder. So our simulations are able to right away rule out and rule in which mechanism is even plausible from a mechanical point of view. So what's great about this is that gives us evidence also that we can guide experimental hypotheses. So now we would expect to look at these specific muscles from our simulations and expect them to be short if we were to do an experiment. But we do need to move into experiment because we need to understand other features that are not mechanical. There could be contributions from the nerve injury for the sensory nerves. You're also not using this limb at all or not properly, so there are disuse issues. There could be other effects on bone. And we need to know more about the time course of change so that we know when to operate on these patients. Sometimes these patients come in and they're injured at birth and they may not operate for a year or even 3, by which point it's way too late for these types of morphological changes. So we've moved into a rat model of brachial plexus injury where we can inflict nerve injury at birth in neonatal rats. We have basically the only group in the world with our collaborators at Cincinnati Children's working together to create these neurectomies. And that allows us to make direct measurements of bone and muscle tissue at the micro and macro levels. The neurectomy model that we have is really exciting because we can be a little even more particular about where we create the nerve injury to represent 2 different clinical cases. If the nerve tears in the middle, oops-a-daisy. If the nerve tears in the middle, it's a rupture, and those patients have really severe shoulder contracture. Whereas if it pulls straight out of the spinal cord, that's called an avulsion, there's limited shoulder contracture. So it also allows us to have a standard amount of nerve injury while distinguishing between the effects of contracture and no contracture on bone growth. So after a nerve injury, then we can wait 8 weeks and then we're able to make direct measurements of those muscle parameters that we have in our musculoskeletal model, as well as the shape of the bone. And we're specifically looking at the angle of the glenoid, whether it is tilted down and whether it is tilted backwards. We can also make functional assessments. So we have little rat treadmills, and we're able to measure range of motion directly in the animals as well. So what we see right away from CT scans and reconstructed volumes is that we have a good model of brachial plexus injury because we're able to detect an uninjured, nice ball in socket glenoid in an uninjured shoulder, and we have very clear deformity of the glenoid in an injured shoulder that is consistent with what's observed in human patients. if we look at our two groups, I'm showing here first range of motion and glenoid inclination angle, which tells us about the deformity that we observe. 0 would mean no deformity relative to the other healthy side of the animal. So what we see for green, which is where we expect there to be shoulder contracture and we expect there to be bone deformity, there is, it's lower than 0. And the blues, there's no deformity, so there's, it's right at 0. So then we would expect that we would see muscle changes consistent with this. And based on our simulations, we would think we should see short muscles for the green. But what we actually see is that while there's short muscles and small muscles for the green, we see much worse muscles in the blue. So that's sort of surprising. They're very, very short and they're very, very atrophied, but they have no deformity. And that is surprising to us. So our question is, how do we explain contracture and bone deformity if it's not directly, we can't see it immediately from looking at the relationship in these muscles? Well, that allows us to turn back to modeling. And the great thing about modeling is that we have other methods where we can now directly relate these bone, not just in a correlative fashion, but we can directly relate what the changes in muscle is to the mechanics of the tissue growth itself. We've done this by understanding that there are two contributors to bone growth. There's mechanical factors that are, so bone will be added or taken away in response to the stress state at a specific location within the bone. And static loads encourage bone resorption and dynamic loads encourage bone addition. But there's also biological factors that are related to cell activity. So the more cells that you have in an area, you would have more bone growth, and the fewer cells you have, you'd have less bone growth. And these have all been characterized based on experiments in growing bone. So we can represent this mathematically inside of a finite element model where we start from an initial bone geometry, we apply a load, we can measure the stress state and get a rate of bone growth based on the mechanical stimulus. We can also estimate the cell content and estimate the biological growth and combine those two stimuli into a single new bone geometry. And we do this using a thermal analog in our finite element simulations so that essentially each node experiences a temperature change that is proportional to the growth stimulus from either the mechanical or biological stimulus. We use that to displace the nodes, create a new bone geometry. And then we can do this iteratively so that the next step would start from the new bone geometry. And these simulations also incorporate that differential effect of dynamic or static loading, so that for a static load, we might see something that would ultimately grow like this, which may start to look like a joint to you. And when there's a dynamic loading, in this case, it was a cyclic asymmetric, just rotation back and forth, you would get a totally different shape for the same magnitude of force. So we've incorporated that not only in these simulations, but in the framework of a larger tool we've developed that allows us to integrate our dynamic simulations with our finite element simulations, so that as you change those muscle parameters of atrophy or shortening, you can feed that as a boundary condition over to the finite element model. The finite element model grows, and then you can feed that growth information back to the dynamic model to make that model grow over time. So you can actually now kind of grow the whole system over 8 weeks or whatever you would like, so that it mimics your experiments and you can make direct comparisons. So that's what we did. We simulated cases where there was a typically developing shoulder and a dynamic motion. We simulated a static condition where there was paralysis, and then we simulated static conditions with changes to the muscle structure itself that were derived from our experiments of a rupture or an avulsion, so that the muscle changes themselves were directly represented. So then we could see what the effects of each of these pieces were independently. And again, we looked from our simulations, although we had the whole bone shape, we extracted these characteristic measurements so that we could compare them to our CT measures. So what we found is that if we start from the same geometry, and we derived this from images taken from neonatal rats, so we knew what the joint shape should be at birth, and then we simulated it over 8 weeks, looking at 2 of the conditions right away, you can see that we predicted a healthy looking glenoid for a dynamic, typically loaded shoulder, and it predicts flattened and declined joint configuration for a paralyzed and restricted muscle growth case, and that these match really well to the images of the same animals at 8 weeks as well, which was pretty exciting. It also gives us an opportunity to see how the shape evolves over time, so that in future work we can start understanding whether different interventions applied at 3 weeks or 5 weeks can either stop or reverse the progression towards deformity. So looking at our specific cases just qualitatively, you can see that the dynamic loading kept that curvature. You get flatness from only paralysis with no muscle changes, which is kind of interesting, and something that we will talk about more in a second. For our cases where the muscles change, you can see there's more severe flattening on the left when muscle growth is restricted. But when there's severe muscle growth restriction, but also atrophy, you start to see more of a normal glenoid again, which is really consistent with what we saw in our experiments, that even though there were severely shortened muscles in the avulsion case, they still had no deformity at the shoulder. And that's very consistent now with what we predict mechanically should happen. When we actually turn to quantitative estimates, we see that our simulations fall right within the experimental data, which was also very exciting to us, that this worked as well as it did. For the normal case for restricted muscle growth, and a similar behavior, although not identical, for the restricted muscle growth and mass loss, probably because it's not totally there's more movement in the experimental shoulder because it's flaccid and it just flops around. So one thing that was interesting out of those simulations is that there was flatness just from paralysis without any muscle changes, that the static loading itself was detrimental. So to get at that, we've developed another novel animal model in which we disarticulate or amputate at the elbow for the rat to encourage them to use their limb in the same way that the neurectomy rats do. The rats who have had neurectomy tend to either not walk on their limb or they walk on the elbow because they don't have full motion of the shoulder, of the limb. So to get at that without a neurological deficit, we used an amputation model, and we were able to show that they walk really similar to the animals who have undergone a neurectomy, to the postganglionic ones, to the ones that are avulsed. So green and red match in terms of their range of motion and other features of gait. And so if indeed our simulations are correct, what we would expect is that we would see a disrupted glenoid development just from walking badly and not from the neurological deficit. And in fact, we see that. We see a glenoid deformity that is very similar to the rupture based solely on the fact that they are using their limb in a different way. So that really emphasizes the importance of the mechanical loading and actually gives us insight to clinical treatment, that even passive mobility of the shoulder would be really, really important for maintaining that joint configuration. So to just wrap up this section, we've developed unique computational and animal models of brachial plexus birth injury and forelimb disuse. We have developed a simulation platform that allows us to show that altered mechanical loading alone is sufficient to explain major features of glenoid deformity in this patient group. and showed that both restricted muscle growth and atrophy are essential to understanding contracture and bone deformity in these patients. So just real briefly, the techniques that I've shown you today, we are really focused obviously on the upper limb, and I've shown you a couple specific applications, but we have and can use these for lots of other types of interventions to nerve, muscle, and bone. We've looked at nerve transfers and grafts where intact nerves are used to reanimate paralyzed muscle, muscle transfers or release where muscles are rerouted to cross other joints, and bone osteotomies where a bone is cut and reoriented to change its conformation. And we've developed simulations of most of these, and others in our field have worked on bone osteotomy. Similarly, we're really focused on the shoulder today, but there are many joints that have similar clinical considerations, and we have looked carefully at the shoulder and rotator cuff. Others have used similar approaches to consider hip dysplasia in developing infants, and we have been working with Matt Fisher in BME to look at the development of the knee and made similar predictions for knee growth. So in conclusion, our simulation approaches elucidate biomechanical principles underlying injury and treatment, especially in the upper limb. We specifically choose outcomes that are parallel to clinical or experimental assessments so that we can have translation of results and improve our experimental design and hypotheses. And in turn, we use our experiments to provide essential data to drive our simulations and ultimately provide direct mechanical explanations for observed phenomena. So none of the work that I showed today would be possible without my excellent student team and collaborators, amazing students that have been working with me and continue to work with me in the brachial plexus team and the movement analysis and modeling team. We have excellent clinical collaborators that provide their insight and also access to their patients at Cincinnati Children's and the Rehab Institute, Chicago, Stanford, Duke, Wake Forest. And then our funding sources as well from a variety of sources. So with that, I'm happy to stop and take any questions in the minutes that we have remaining.
Awesome, thank you, Kate. So if anybody has any questions, you can put them in the chat window, or feel free to unmute at this point and ask. And I can start. It's only tangentially related to your talk, unfortunately, and you may not have a good answer, but you mentioned early on how the materials involved are dynamic in terms of their mechanical properties, and that's always been the most confounding thing for me in biomechanics problems. I'm used to material properties basically just going in one direction, right, due to degradation in something like a polymer composite. But what you're doing here, you have to consider, are the mechanical property changes associated with like aging and damage or even healing, or go the other way, are those large enough that you really have to consider those? And if you do, how do you do that? Is it primarily experimental?
Yes, so great question. So the finite element simulations I showed today, we started from a constant material property and focused on the change in shape. But we're also really interested in the change in the tissue material itself, which we would refer to as maturation, and for soft tissues and for calcified tissues like bone. So we do require experimental information. We've worked closely with Jackie Cole's group, who has expertise in the microstructure of bone. The CT scans in the rats that we've made give us additional information about that microstructure that tells us something about what the stiffness would be in a given region. And we've done earlier work, in my group, where we've done finite element models where like the density essentially, and essentially the tissue modulus is regional and changes over time. So these are definitely things that we can and plan to incorporate more in these simulations. Similarly, for the dynamic modeling, we have used imaging quite a bit, MR imaging, to understand the fat content of muscle, which does change with injury, and the structure of the fat, whether it's homogeneously distributed or tightly clustered, all of which will influence how much contractile tissue there is and how much force can be produced. So that's something else that we've directly represented in our models in a variety of ways.
Okay. It sounds as complex as I expected, right? And difficult to do. So no surprise there.
The fun part, because that's the part that, I mean, all pieces of it change with age, but that part is really important. Yeah.
Mm-hmm. Yeah. Okay. Thank you. Looks like, if you can see the chat window, looks like Anna has a question there.
Hold on, let me get it. Okay. Are changes in treatment plans already happening? Are they all in the future? Yeah, so our relationship with clinicians is pretty tight. About half of our work is published in engineering journals, and the other half is published directly in clinical journals, so that the clinicians will see it and they will use it in their work. And we have found that we do influence the way in which treatment planning happens. We've influenced the understanding of what they're seeing on images and how they use those images in their decision-making process. We have quite a number of simulations that are really directly answering questions about, this simulation, this treatment versus that treatment, so that it gives more information to the clinician about how to make a choice. And all of that work is, work that we present at clinical conferences. And I guess one more point to that I'll make is, we have become very integrated into the clinical community. Our brachial plexus work, there is now a consortium that is pretty much expert orthopedic surgeons working brachial plexus, and Jackie and my team. And it's called Plexus Nexus, and we work together to get the word out to patients the parents of patients who have experienced this injury, how to get treatment and how quickly to get treatment and where those treatment centers are. So we feel really fortunate that we can be that closely integrated with that team.
Okay. Any other questions? We've got time maybe for one more if anybody wants to unmute, or looks like maybe Young is.
Hey, Kat. Yeah, this is Young. I have a quick question. I think for the first part of your talk, you mentioned use the EMG, right? And then has some trouble to get the force output. Right, you said it's not direct, and then it could be noisy. Right? I was wondering, is it possible to get some sensor or other techniques to directly get the force?
Yeah, so I'll answer that kind of in two ways. There are different methods of EMG that have different levels of sensitivity. Most EMG is a surface EMG signal that is very noisy because it comes through muscle and bone, fat and skin, and depending on where you place it, you might get better information. There's also fine wire EMG, which goes directly into the muscle and is a more sensitive measure. And then there are colleagues in BME who are using more of a sleeve of sensors that allows you to get more precise measurements. But the challenge with EMG remains that it, even when you have a fine wire EMG, that people don't typically move the way that they normally would when they have needles in their muscles. So, that can be a difficult problem. In terms of directly measuring force, it's extremely difficult. There really are no good methods for doing that in vivo in humans. There are some studies where like a buccal transducer or something will be placed directly on the tendon, like on a large tendon, like an Achilles tendon. But those are typically in animal models, like, there are various birds that are really good models for that. There have been some efforts to use, for example, like intramuscular pressure and putting in really small implantable pressure transducers inside of muscle. And that has some success, but is still not precise, and it's very difficult for dynamic motions. A lot of these things work better for really slow or maximal contractions and are not very good for like pitching, right? Or something that happens that has a lot of motion. So it's a really good question. It's a difficult question. There is a group recently that has been doing some really interesting work using like an indenter basically that hits the tendon while people are walking, and in concert with ultrasound probe allows them to get some other estimates of what those forces might be in vivo. But it's really, this is a really important question for the field.
Yeah, thanks, Kate. Well, that's the indenter method sounds scary.
Yeah, I mean, it's sort of more like, you know, like a hammer that a doctor uses to hit, you know, to do the knee test, right? Sort of that kind of thing, but it knocks.
Okay, thanks. Yeah, I kind of see it's hard to measure the force. Well, I'm asking, just sort of thinking if there are any ways, like say from mechanical engineers can help.
Yeah,
maybe it's easier to measure deformation. I don't know if one can measure the deformation of the muscle. So maybe through your model or some modeling can back out the force.
Yeah, that's exactly right. And that's sort of where we've been going as a field to do more robust validation of some of the models. One is using ultrasound in vivo, like while performing tasks to measure directly the strain in muscle and tendon. I attended a really excellent defense yesterday where a student was doing that. And the other, you know, approach that is used that doesn't really help for healthy people, but has advanced the modeling field tremendously is it was a knee grand challenge, and I think now there is a hip grand challenge, where there is a suite of patients that have received a total joint implant replacement, where the implants themselves have sensors. So they're able to directly measure some of these joint loads, and then you have really precise medical images from the individuals, and they've collected a really great comprehensive data set on a small subset of people that have these implants so that they can be used to validate workflows.
Okay, great. Yeah, thanks, Kate.
Yeah.
All right, we will wrap it up there. Thank you, Kate. Great talk. Thanks everybody for attending. We've got a few more seminars left in the semester, but not many. So hopefully I'll see all of you next Friday, same time. Thank you again, Kate.
Thanks, guys.
Take care, everybody.